register before midnight tonight. And we would like to thank you in advance for putting your microphone on mute once the presentation begins, being attentive to the presenter, being engaged, and of course, completing and submitting the evaluation form at the end of the session. Our Grand Rounds is brought to you by our educational partner, which is the South Central Area Health Education Center, which helps our department's mission statement of inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. We've gone over this a few times, but if anybody needs help with CME transcripts, you can go to the CME website and you can log in there and view your CME records. But if you have questions, you're more than welcome to email the CME office, or you can email me as well. And you can also claim AAFP credit for this presentation today. If you are an AAFP member, the information there for their phone number and their website is available, and I can also assist if you have any questions with that. Dr. Ravi has no relevant financial interest with commercial interest to disclose. So she will be presenting for us today. She's going to present Cultivating Scholarship for Family Medicine Residents. She's one of our very own, so I will let her take the meeting.
All right, thank you. Good afternoon, everyone. Thanks for inviting me to do this Grand Rounds on Cultivating Scholarship for Family Medicine Residents. I am an associate professor at UT Health San Antonio. I did residency here. I've gone through our research curriculum, and now I'm one of the faculty leading that curriculum that we have here. All right, so here's what we'll discuss during this talk. So we'll first talk about what defines scholarly activity. We'll especially talk about how ACGME defines scholarly activity and what constitutes scholarly activity per the ACGME. Then we'll talk about the ACGME scholarly activity requirement for family medicine residents and faculty. And then we'll go into some examples of successful scholarly activity initiatives that have been instituted throughout the country. Finally, we'll end with some discussion of factors that can challenge and facilitate resident scholarship. We'll also, at this time, we'll talk a little bit briefly about what we do here and how it's impacted resident scholarly productivity and all its other outcomes. All right, just a little background on resident scholarly activity in family medicine. So in 2006, the Review Committee for Family Medicine from the ACGME began to require resident scholarly activity. 3 years later, in 2009, there was a national survey that looked at how successful programs have been at having resident scholarship. Most programs, 76% of family medicine residencies reported some kind of research curricula, but most of them, 87%, reported that less than 25% of residents published manuscripts. And most of them, I guess 80%, had fewer than 6 resident presentations at conferences preceding 2 years. So there was still a long way to go for improving resident scholarship in family medicine. So what is scholarly activity? The ACGME describes it as contribution to knowledge available to the discipline of family medicine. They describe several areas of scholarship. They include discovery, integration, application, and teaching. The ACGME put forth a nice table with examples of each of these areas. You know, discovery, what you think, basically doing a research project to find a new drug or a new way to treat patients. Integration is basically an example of you just, synthesizing the knowledge so that it's a bit useful to your fellow physicians and others. For example, writing a book chapter or performing a literature review and publishing that. Application is, applying, let's say, a quality improvement method to improve patient care in your clinic. or impacting healthcare policy. These are all examples of application. And of course, teaching, an example of that would be creating a new curricula for residents. Let's say, for example, in our clinic, residents have improved inpatient curricula, and also we have a new LGBTQ curriculum. So those are all examples of scholarly activity, and these are all the different various areas of scholarship. In general, to be recognized as scholarship, contributions must be shared with peers and be subject to peer review. Okay, we'll talk next about the ACGME scholarly activity requirements. These are all up to date as of July 2020. Small changes have been made. In general, residency programs should create a scholarly atmosphere, an environment that can stimulate residents' critical thinking skills, an environment where we can challenge the evidence that residents use to make their medical decisions. Should be an environment that fosters curiosity and helps them learn, lifelong learning, that fosters lifelong learning. And it says to teach residents the scholarly approach to patient care. And that was interesting. So what's a scholarly approach to patient care? So they define that, and I really like that definition. So basically, the definition is the scholarly approach can be defined as a synthesis of teaching, learning, and research with the aim of encouraging curiosity and critical thinking based on an understanding of physiology, pathophysiology, differential diagnosis, treatments, treatment alternatives, efficiency of care, and patient safety. So that's a pretty broad definition, and it's, it was interesting for me when I read this and I said, am I doing this with each time I'm precepting residents in clinic and hospital? I mean, a lot of us do it to some extent, but it's good to have this approach in mind when we're residents. So both them and us can get the most out of the time that we spend that the residents spend in residency. So we had talked about, kind of the atmosphere that the residency program needs to create, a scholarly environment. Now we'll talk about the specific requirement for residents. So there's a general requirement that says residents must participate in scholarship. It's pretty broad, but there's also a specific requirement that says residents should complete 2 scholarly activities by the end of their residency. So each one should complete 2. At least one of them should be a quality improvement project. Okay, and then there's a requirement for faculty. So it's kind of broad. I think in the past there were certain requirements for individual faculty, but now it's they look at the faculty as a whole. So basically it says, to demonstrate accomplishments in at least 3 of the following domains. It's like a lot of different domains. It's research, peer-reviewed grants, quality improvement. Goes all the way to, being involved in professional committees, educational organizations, creating, innovations in education. So that's demonstrate accomplishments. And then faculty also have a requirement to demonstrate dissemination of scholarly work within and outside the institution. So this will be reviewed in a 5-year interval, and it's and the faculty are judged as a whole, not individual faculty. So, but this talk will talk more about resident scholarship. So throughout the US, there's been many programs that have tried to put forth, implement scholarly initiatives. There were several successful ones. Some of them are, they learn from each other, and there's some similar ones. One successful program basically instituted a point system for rewarding resident scholarships. So the residents, for all the different scholarly activity, they were assigned certain points. A lower number of points is for something that's, that doesn't require so much time, preparing for grand rounds and presenting grand rounds, submitting an abstract, whether or not it's accepted, those will all be like 1 or 2. And then, let's say if the resident completed an IRB approved project that's well done, and they're able to, they put forth a publishable manuscript, and then that's 10 points. They all have to have a minimum number of points for graduation, and then there's awards given to those who achieve high points. So that's a point system that a couple of different programs have implemented. And this specific program also implemented, they appointed a faculty research coordinator and a resident research coordinator. I've seen a lot where there's been a faculty appointed to help the residents achieve their scholarly activity goals. But this was one of the programs that implemented a resident coordinator. So resident coordinator was a resident in the current resident in that program. They've had some interest, well, they've had some experience in their undergraduate performing research, and they have some interest in helping others conduct research in their residency. And this person basically acted as almost like a mentor for the residents and guided them as to pick how to pick projects and how to achieve their minimum number of points or go higher if their goals are higher. And they also had some workshops on IRB and different things. So this is one program. And then there's another program that had a longitudinal resident research curriculum to help with research and QI education. And there was a concurrent faculty guided development of project ideas. So this program had assignments with deadlines that residents had to complete. And over the course of a couple of years, they have to come up with at least an abstract that can be ready for conference submission. That's another one. And then a lot of programs basically implemented a local research day. It seemed simple, but it was very effective at motivating the residents and the faculty to conduct scholarly activity and also collaborate with the community. And there was a lot of, even though it was a simple, just one real initiative that they did, it had profound impact on the type of projects that were done and presented and published. Next, we will talk about our curriculum. Our curriculum began, this is at UT Health San Antonio, began in 2014. That was when it was formally implemented. But even since 2009, 2010, our residents have been pretty involved in scholarly activity. We have Dr. Burge. For those of you who are not familiar with her, she was a behavioral science professor who had extensive experience in research, and she collaborated a lot with our clinical faculty in research projects. And she acted like a very good mentor for residents, guiding them in completing their scholarly activities, doing QI projects, research projects, a lot of different things. So we had already been pretty active in research, but then and she also gave a lot of didactic lectures. But in 2014, she is the one that implemented this curriculum called Research Hour. Research Hour is basically a monthly 1 hour long session for residents that takes place during their routine didactics Wednesday afternoon. It consists of a 20-minute lecture or didactic type activity followed by 40 minutes of small group activities. So the type of didactics included, getting started in research, generating ideas, quality improvement tools, different types of research in healthcare, research statistics for medicine, and finally communicating results. These were all, we picked up, the topics that were picked were all pretty relevant to the types of projects that residents were doing. So residents, it was pretty useful. It's this research hour, Dr. Burge has hired. Now it's being led by 2 clinical faculty and a staff from our department's research division. So the lectures are usually given by us, and I'm one of the faculty that helps with this. And then after the 20-minute lecture, there's a 40-minute small group activity. Now this has changed quite a bit since COVID. We can't really do small group activities that much, but we're trying to do some hands-on activities still. And today, for example, we'll have a research hour and we're trying to break people into breakout rooms, and maybe they'll have some small group activity in that way. But usually in general, the small group activities included, brainstorming for if they're an intern. Interns would get together and brainstorm their ideas, and we get to know what they're interested in. And then once they've identified an idea, we'll use that time to match them with mentors. And depending on where they are in their project, sometimes they have questions about IRB submissions. Often groups that worked on the same project would get together. At that time, it was a protected time where they could talk with each other. And we had our departmental statistician, Dr. Wood, who was attending these sessions as well. So they would ask his feedback and his assistance with data analysis during this time. And when there was time for poster submissions or abstract submissions, residents would get together and come up with, questions about their abstract and posters. And there was a good time for, the residents who were already taking part in scholarly activity to share their interests with the interns and pick up people who would carry on their projects after they graduated. So it was a good, the research hour was pretty effective. Just this year, it's been a little bit of a challenge to keep the, small groups going. And then besides research hour, we also have in general throughout the year different community events, which are often planned during research hour. These include, community needs assessments, health fairs, targeted educational events. This is another venue for, coming up with scholarly activity and also presentations and things. And then in the second year, the residents, you see this third column here, the residents complete a community medicine rotation, and they all work together on this longitudinal year-long quality improvement project. So that's another opportunity they have to conduct scholarly activity. And then these red arrows are here just to show that, all of these don't occur in isolation. We, during research hour, all the scholarly activity that residents do are kind of discussed, and so that everybody's aware of what's going on. So it's all pretty integrated. And at the end of the year, all the way end of the academic year in June, we have a scholarship day. We call it Community-Oriented Primary Care Day, where we basically celebrate the scholarly work done in the past year and the community engagement we've had in the past year. We also have a poster competition for residents and faculty, and awards are presented to the best posters. So anyway, so this is our curriculum. There's a lot of different components to it, and we have ways of, encouraging residents to continue on their scholarly activities. So some facilitators for resident scholarly activity. So these are all the factors that many programs around the country have noticed that were associated with higher resident scholarship. For example, formal recognition of scholarship, dedicated research time, having a local research day, having the program director's support of research, and if they're involved in research, that was another facilitator for resident research. Having a research curricula, and having professional support like the support of a research division to help with IRB questions, or the presence of a departmental statistician to help with data analysis. These were all factors associated with improved scholarly activity for residents. Okay, and I have this here. Anyway, so some of the things that we've noticed that that have helped our program achieve the scholarly activity goals, where having a scholarly activity curriculum has helped. We have dedicated faculty to lead the research curriculum. This is helpful because residents know who to reach out to if they can't find mentors, if they are stuck in their project. They always know who to reach out to. We have protected time for QI work, both during research hour and also during their community medicine rotation. And then we also have funds for residents to present at medical conferences. The residents really enjoy, at least before COVID, traveling to different conferences, presenting their work, collaborating with others, finding other ways of performing their same project. They enjoy doing that. And then some other facilitators, we have availability of experienced research mentors. We have statistical support, and we have support from the research division staff. But above all of these factors, I think the most important one is strong leadership backing. We have our program director and our chair who are very, they motivate the residents a lot in carrying through with their scholarly activities. They encourage them quite a bit. And so they basically created a culture of celebrating scholarly work. And even personally, when I interviewed at this program for residency, this was one of the things that really set this program apart. Other programs did have scholarly work, but as far as this culture of celebrating scholarly work, it was very apparent when I interviewed here. And that was something that's helped our residents. Okay, some of the challenges to conduct resident scholarly activity. So some of these are all pretty, we already know about these. It's obvious, time constraints, of course, residents are busy. And then, of course, there's limited resident knowledge of research and QI methods. Sometimes there's a reduced number of faculty mentors, especially if the residents have a specific interest that none of us are really familiar with in that topic. That might be difficult for them to do research in that. And of course, there's, year to year, there's some variability in residents' commitment to research. So next I wanted to talk about some of the outcomes of the curriculum that we have here. You can see this is a timeline of our productivity. So the curriculum began in the year 2014. And this blue line represents number of residents who co-authored posters, and the orange line represents number of residents who co-authored book chapters. And the book chapters were mainly for the 5-minute clinical consult. And there were a few for, the AFP and some other things, but mainly it was a 5-minute clinical consult. So you can see after the curriculum began, the number of residents who co-authored posters went up dramatically initially. That was a bit of a dip right after that. I'm not sure exactly what that's for, why that happened, but after that, there's again been a steady increase in the number of residents who co-authored posters. And then for the number of residents who co-authored book chapters, there's been a steady increase since the curriculum began. Then we also looked at the 5 years pre-curriculum and 5 years after the curriculum. So we looked at the percent of residents who co-authored at least one poster 5 years before and after the curriculum. Initially it was 55% in the 5 years, 55% of residents co-authored at least one poster in the 5 years pre-curriculum, and that increased dramatically to 82% of residents co-authoring at least one poster in the 5 years after the curriculum. So that was pretty effective. Somehow it got all the residents involved in doing some scholarly activity and presenting something. Okay, and then besides improving scholarly productivity, the resident projects have had pretty strong impact on patient care in the community. So it's not just about presenting a poster, but it actually has impact on patient care. I'll just go through a few. There's been lots of projects, but I picked some ones that had good impact in the community. So first of all, several projects that they've done have had impact on our understanding of high-risk communities. So there's one project, there's a high rate of childhood obesity in our clinic population and in our clinic zip code. So in order to understand the assets available to them, for example, what resources do they have, how could we help them? There was a project that mapped out the distribution of childhood obesity in our clinic patients by neighborhoods and zip codes. And they did kind of like a windshield survey where they found out, what are the assets available to them. Do they have good transportation, gyms, parks, are there sidewalks to go walking, are there good grocery stores? In the next slide, I'll show you like a little, a product of that. Let me show you right now, actually. This one example, all the little stars are clinic patients. We kind of see where they are. And then, there was also a survey that basically found out what assets were available in each of those neighborhoods. Okay. And going back, we also learned a lot about our other communities, our local Islamic, Indian, and low-income Hispanic communities in San Antonio. We were able to find out their health priorities and barriers, and that's here listed. You can see the community priorities of the different communities. The El Bari Clinic, which is an Islamic community. There's the Indian community, and then there's actually an African American community, I think, called Black Center. Or maybe Hispanic, I'm not sure. Anyway, so we find their health priorities and barriers. This is all very useful information. Okay, and then we've also improved preventive care by improving hepatitis C screening in baby boomers, improving zoster vaccination, improving health maintenance by implementing increased adult wellness visits in our family health clinic. And here are some more projects. There was a small pilot project that was fully initiated by a resident where they prevented progression from pre-diabetes to diabetes. There was another inpatient project that looked at reducing hospital readmissions by providing targeted education to the residents and faculty. So it's, you know, these are all pretty important outcomes. So it's not just resident scholarly activity just for the sake of doing scholarly activity, but it actually impacts patient care. And some more outcomes of our curriculum, you know, we don't think about medical student related outcomes, but many of our residents have worked with medical students in their projects, whether it be in the community or in the clinic doing QI projects. You know, medical students are able to get good research experience, they get quality improvement experience, they are able to collaborate with residents, and they get a good exposure to family medicine. We've had lots of, you know, even medical students, high school students even come to our health fairs, and undergraduate students who are interested in medicine have been involved in our project. All of them have a good exposure to primary care and the importance of it. And of course, there's faculty-related outcomes. And of course, you know, even through mentoring residents, me and several other people have gotten improved knowledge of the resources that are available to us. And while mentoring residents, we become a better family medicine physician and an educator. And of course, we also get to take part in the scholarly activity productivity. You know, our presentations, we're able to publish. So it helps everybody. And some improvements that we have planned for our curriculum would be, you know, we've had a lot of poster presentations, but we don't have many peer-reviewed publications. I think when I looked through, there was probably just one or two over the last, you know, since 2009. Mainly it's the book chapters that we have. As far as publication in peer-reviewed journals, it's really lacking. So the next step is to somehow train our residents better in writing and publication. It might be scary for some residents to think about it, but I think as long as we are able to guide them, they'll be able to do it. And we're also evaluating our curriculum's impact on actual resident knowledge of research and QI methods. That's something that's ongoing. Okay, any questions so far? It's pretty brief. Anything that you all have noticed as far as what are facilitators for resident scholarly activity, or any barriers that I haven't mentioned?
So I can make a couple of comments, but I don't want to steal your stage before you make your summary.
No, I'll make my summary at the end.
Okay, so I first of all, I just want to congratulate you on the talk. A lot of times we talk about processes, but you have actually measured outcomes that we have within the residency, and I think these are really important outcomes that really show some of the progress that we made. I think our timing was pretty good, right? So I've been here since, as the residency director since 2006, when they made it a little bit more mandatory at the ACGME, and we've been, we embraced it then and been working on it since then. And I think you've done a great job sort of chronicling the steps forward that we've taken, and I appreciate that. As a member of the Family Medicine Residency Review Committee, I can tell you I look at a lot of programs, and most of them aren't doing anything near like what our residents are doing here. And I think a lot of it has to do with the infrastructure we have here, right? It's not just like you get a blank sheet of paper and say, oh, go do some scholarly activity, right? We've got faculty here to teach, to encourage. We've got resources here to support us. And a lot of places don't have that. And so, you know, from the early days, the faculty have embraced it. I want to thank everybody. Specifically, I think we've gotten tremendous support from Dr. Catterall, Dr. Burge. I want to give a shout out to Dr. Woods. Most places don't have somebody who can give you such a understandable look at the statistics, right? I think a lot of us find that to be a unique ability to make it seem understandable, even to us statistical neophytes. So I'm grateful for that. I think I want to thank my boss. Dr. Han has provided a lot of cheerleading, encouragement, and financial support for a lot of these activities. And I think that's been a big benefit for us. I think the secret sauce really though has been the residents, right? So by the time we've got a bunch of resident outcomes like this, we actually have a knowledge base within the residents themselves. And I think that's helped us really develop and sustain momentum that very few programs actually have. I'm going to make the point that Dr. Burge was kind of our biggest cheerleader when she was here, kind of a unique talent in terms of helping us get this done. And so when she retired, I asked Dr. Ravi, Dr. Ali, and Dr. Cruz to pick up the mantle there and to lead us forward. And they've really applied great energy and consistency, which I think has been extremely helpful for us. Another thing I would point out to be extremely helpful is we've had a number of different venues that we can present our scholarly work, and I think presenting something publicly is encouraging for most of our faculty and residents. And so we presented at the Alamo chapter, the TAFP, the NAPCRAG, the SDFM, so a variety of regional, national, international venues. And we've had some fun with that. I think if you can successfully do that, that's been successful. We have more advanced residency research networks, I think, than most places do. That was actually, I think, masterminded isn't too strong a word, by Dr. Burge. And that has a long history of success here in Texas. I want to give a shout out to Dr. Cancino, who's helped us up our game a little bit on the QI part. So we are doing QI things here, and Dr. Ravi chronicled many excellent projects that we've had. And now we have the opportunity to do quality improvement work within a different type of practice over at the primary care center. And that, I think that's really helped us a lot. And then just lastly, I wanted to, Dr. Ravi gave a shout out to the medical students. We've had great experience, great relationships with some of the students. We had two of our students, Meredith and Hasek and Dylan DeMuth. They were the lead on a project that a bunch of our residents and our faculty worked on that won a recognition at this year's UTUSCA Research Day. So I think the partnerships that have come out of this have been really important too. So thank you for the summary, Tharani. I really appreciate it.
Thank you, Dr. Nato. That was a good summary of all the facilitators that we've had. We've had a lot. So it's all
well, once you start naming names, like I'm sure I left a couple of people out, but I did want to give a shout out to a specific few because I really do appreciate the energy that people pour into this.
Right, right. Yes.
Dr. Ravi.
Yes, go ahead, Dr.
Excellent presentation. Thank you so much for putting it together. I particularly like the fact that you have now turned to a very important step that we have been missing. And it's the fact that, you know, part of the definition of a scholarship is that you need to be able to disseminate your knowledge. And when you present a poster, that's a form of dissemination and it counts and it should be celebrated. But a poster doesn't end. We should make sure that we do the transition to then communicate that in a form of a manuscript or some other form that is then accessible for more people. So I'm very excited to hear that that's the direction we're going. And for the residents who are participating, you know, once the hardest paper is the first one you write, but the next one gets easier. And we have several faculty here to have excellent experience and can provide some feedback. And then we also have a forum once a month in what we call the research tea, where a draft of a paper can be reviewed and you can get feedback. So the structures are in place, and you know, we are committed to inventing a healthier future for our families and communities we serve. And part of the inventing is creating new knowledge and then disseminating it. So I just want to echo the celebration. We need to continue to celebrate, and as you know and others know, that, you know, whenever we invade national and international meetings, we have a strong presence, and often our colleagues from other institutions are very impressed with the work that our residents and faculty are presenting. But there is one more step that we need to take on, and that's manuscripts. But thank you again. It's a wonderful presentation.
Thank you, Ryan. So yeah, we already made the little modification to our curriculum this year. I think Dr. Ferrer is going to give a talk at the end of this year about how to write a manuscript. So then, we'll start there, and we'll, the next year, each year, we're kind of modifying the curriculum to incorporate that a little bit more. And next year's curriculum, we're planning it. We'll keep that in mind, and how to encourage residents to actually start writing. And the important thing is, recently I wrote my first paper, and I had lots of help. I didn't do it on my own. I basically asked 5 or 6 people for help, and they all gave, and then I went to the research team, which was very helpful. A lot of them, you get a lot of people's opinions at the same time, and it's a good time to kind of talk and collaborate with others. And maybe you're missing an idea, and they'll kind of give it to you.
And it's important to highlight that Dr. Ferrer is the associate editor of the Annals of Family Medicine. And the Annals of Family Medicine is a premier worldwide primary care journal. So we have top-notch component in here. And of course, we have Dr. Cannondale, who is an amazing, very productive and very experienced writer.
All right.
Many more.
All right. Thank you, Dr. Hyan. So I just wanted to end with, just a summary. Most of us are familiar with the resident scholarly activity and what's required. It's pretty easy to do. A lot of our residents, well, all of our residents end up meeting the guideline, the minimum requirement just by the course of their residency. But most of them take it a step further to get engaged in further scholarship, and be involved with the community, be involved with QI projects. And of course, I outlined a variety of strategies that residencies have used to improve scholarship. And as you can see in our institution, we have, employed, it's all a combination of all of them, interested faculty, dedicated faculty, dedicated research time, curricula, ways to present the venues to present the work that we've done. And it's still important to kind of keep the barriers in mind as well. Resident, the time that they have, and each class is different in terms of prior research experience. It's good to acknowledge that and get to know them early on in their intern year to figure out where they're coming from. And of course, always keep in mind that, residency scholarly activity doesn't just stand on its own. It impacts patient care, faculty, and medical student scholarship. All right. That's it. That's my talk. Any other comments or questions? All right. I think we're good.
Thank you so much, Dr. Ravi, for joining us today, and for everyone. Please remember, I put it in the chat box, but if you can please help us give her some feedback. There's a link there to fill out the evaluation, and we appreciate everybody being here today. Thank you very much.
Thank you.